Thank you for turning my microphone on. I'm here today to introduce House Bill 1190, a bill that will have New Hampshire join a new interstate occupational licensure compact for social workers. When passed by 7 states, this compact will allow licensed social workers to practice across state lines through telehealth or in person. In other words, if you are receiving mental health services and move from one compact state to another, you can keep your provider. If you hire a new social worker to join your New Hampshire agency who has a license in good standing in Vermont or Massachusetts, no longer will you have to wait months to see if that person can obtain a New Hampshire license. If both states are compact members, the new hire can report to work the very next day. I don't think that I have to convince anybody here that we have a mental health workforce problem. The New Hampshire Community Behavioral Health Association, representing the 10 New Hampshire community mental health centers, reported in January 2024 that there were 325 clinical vacant positions across the state. Most clinical positions are master's level practitioners, and most master's level practitioners are social workers. A 2023 performance audit by the LBA on mental health workforce licensing indicates that portability of licensure remains a major obstacle to attracting new mental health clinicians. While recent laws have been passed to expedite portability, processes to do so within OPLC and the relevant boards are not fully in place. So that's what we're talking about here today, is portability of licenses. When somebody has a license someplace else, for them to be able to practice in New Hampshire. The mental health workforce shortage is a complicated, multifaceted problem involving inadequate funding, low salaries, high levels of student loans, difficult, stressful work, et cetera, et cetera, et cetera. I know you've heard all this. I'm not going to lie to you. If you pass this bill, if we join the Social Work Compact, if a number of licensed social workers come to practice in New Hampshire free of bureaucratic hurdles, this will not solve the mental health workforce shortage. Here, however, is what it will do. First, it will provide one more tool to attract seasoned licensed social workers to either practice independently in the state or take jobs in many understaffed agencies and therapy practices. It will allow social workers from other states with a specific area of expertise that doesn't exist in New Hampshire or exists inadequately in New Hampshire to practice by telehealth to give that specific level of expertise in certain areas in New Hampshire. Third, it will have an immediate positive impact on our military families who move frequently. The Department of Defense, through its Office on Military, Community, and Family Policy, is a major player in developing and supporting healthcare compacts around the country. For these families, it means that members can keep their providers when they move, and social work spouses can obtain work without having to apply for a license each time they move. New Hampshire has joined several indispensable healthcare compacts, including those for physicians, nurses, OTs, PTs, psychologists, mental health counselors, and I think there are more. I know that there are those with legitimate concerns about finding ourselves in an ineffective or poorly run interstate organization. It's a legitimate concern. If that becomes the case, we can leave. We have done that too. The New Hampshire legislature passed the law to leave an EMT compact in 2020. So we passed the law, we joined the compact. If we are dissatisfied with how that compact functions, we can leave that compact. HB 1190 passed the House in a bipartisan vote by a 25-vote margin. A Senate bill with identical language passed this body by a voice vote after, I think, passing through ED&A with a 5-0 vote. I urge you to take the next step by sending the Social Work Compact to the governor's desk. And I just would want to say that because this is a compact, because we joined the compact by passing this specific language, this specific legislation, that we are not really able to amend the language in any way in order to actually be able to adopt, to join the compact. I know that that's something that comes up frequently. But in order for us to be a member of that compact, we have to pass a law with this identical language. So I'm certainly willing to take questions if there are any.
Any questions from the committee?
Just one.
Senator, yes.
Yeah, thank you for your testimony. Can you just point me to where the escape clause is, if we're dissatisfied with this and we want to get out of it? Is there an escape clause for us?
Instructions,
Yeah, just what page, that's all.
page 21, construction and severability. You're welcome.
Thank you. I couldn't have done
You were
that.
ahead of me, that's all.
That's okay.
Do you have a question?
Yes, I do, and
Senator
I
Price.
just thank you, Chairman Birdsall and Senator Avon. I spent some time in the interstate compact world, so that's how I could get there so fast. Yeah, so, thank you, Representative, for taking my questions. And I've actually got the map up in front of me, so are we active yet as a compact? What would New Hampshire's role be in this? Would it turn it on? Because it looks like there's pending and there's enacted. You said 7 states to,
Yes, so in order for the compact to begin functioning, which would first involve writing rules and regulations for the compact, there need to be 7 states that pass the identical legislation. I'm not sure, since I first presented this bill to the House committee, which is probably a month ago. At that point, there were 2 states that had fully adopted this language, and I think there were 27 states with legislation pending, including Vermont and Maine. So I think and as you know, if we are one of the first 7 states, it gives us a leg up in terms of being able to be involved in writing the rules and regulations under which the compact will function. And already we have that because the director of OPLC, Lindsay Courtney, was involved in writing the compact language.
great. Thank you again. So, you mentioned early, so I'm just working on, I think I've got this clear. It's a multi-state license, not a privilege to practice. And you talked about established relationships. So you could have an established relationship with a social worker in another state, and using telehealth could continue that relationship.
Correct.
Okay.
Although I don't think there's any stipulation about an ongoing relationship.
Okay.
It's really about the social worker's ability to practice. But the Department of Defense, this was new to me when I started learning about this bill, but the Department of Defense, I think, really is a key player in writing all these healthcare compacts because it's so important for military families who make frequent moves.
Absolutely. And lastly, is your position that this would, provide would be a workforce related bill as well, creating an atmosphere of ease and portability for social workers to come to the state and practice with all the safety
Yes.
constraints in place?
Yes. I think, like I said, the workforce shortage in mental health is much greater and much more complicated than this bill is going to solve. But for example, I live in Keene. I'm retired, but I was a lifelong mental health clinician, social worker. And so when I was elected to the legislature, I got frequent calls from a large nonprofit counseling center in Keene, not the mental health center, but an organization called MAPS, a pastoral counseling organization. And they told me that on many occasions they would hire someone from out of state, either from afar or from across the border in Vermont, 20 minutes away, who had been a seasoned social worker. Well, he was talking about various professions, who had been a seasoned clinician practicing in another state with a license in good standing. And then they would hire them, and the person would want to come and work, and then they would have to try to get a license in New Hampshire. And not that it's impossible, but it was lengthy, it was onerous, it involved sometimes going back and finding a supervisor from years ago, or finding, the courses that they'd taken when they had gone through their master's program. Anyway, it was onerous, and on frequent occasions, they had actually lost hires that they had already made because the portability of licenses were so onerous. Now, we have made changes in the law about that, but my impression is that they're not fully functional within, in this case, the Board of Mental Health.
Any questions from the committee? Seeing none, thank you, Representative.
Thank you very much.
Kendall Snow? Welcome.
Thank you, Madam Chairman, members of the committee. My name is Ken Snow. I'm from Manchester, New Hampshire. I am a social worker. I worked in community mental health for 50 years before retiring 10 years ago. And 48 of those years, I worked right here in New Hampshire. I moved to New Hampshire because it's such an attractive place to live. And I thought I would build my career up here and maybe move back to the big state and the big pond and become a big fish down there. And I quickly lost the big pond, lost all its appeal to me once I started working in this state. And I hope that we can have this bill passed that would have the same impact on somebody else that might stay around for 50 years as I did. Following my retirement, I did run for the New Hampshire House, and I was privileged to serve with Representative Shapiro on the Health, Human Service, and Elderly Affairs Committee. So obviously, I'm very interested in seeing this bill move along. I think nobody needs to remind you that we have a mental health crisis here in New Hampshire, and he's correct. This isn't the final answer, but it certainly is a factor in moving that along. Currently, we have people being boarded in emergency rooms because of the lack of availability of clinicians to operate programs at their full capacity. We have people on waiting lists at nearly every agency around for various reasons. And some of that, but not all of it, is clearly related to the fact that it's difficult to attract people who are licensed and credentialed and properly trained. And we hope it never leads to lowering of the standard that somebody brings about to meet that need, but instead to attract people who have all the credentials that are necessary to do it. And I urge you to consider seriously getting this bill through to accomplish that end. I don't know if there's any other questions that I can really answer. I'm currently not working. I'm retired. Contemplating another run for the House. We'll have to wait and see how that turns out. I'm getting pulled in a couple of different directions on that one. But I loved my experience up here, and I like working on in that particular area on it. And there's certainly a lot to be done, and I'd be eager to once again become a part of it. But I'm not giving this as a campaign speech. No, but I'm really not only contemplating, but whether or not I come in, I would still be very much involved in pushing activities like this forward, or bills like this, and activities like this forward that enhance the availability and professionalism of the services that people that are in need in New Hampshire get. Thank you very much.
Thank you, Ken. Any questions from the committee? Seeing none.
Thank you. I apologize for stumbling around.
Oh, don't worry about it. Lynn Courier Stanley. Welcome.
Again, that's true.
Looks great for St. Patrick's Day.
it was a little late to the game, right?
You can
Thank you.
never be too late. for
Never
I-
too late. Thank you, Senator. Thank you, members of the committee, for hearing my testimony today. My name is Lynn Courier Stanley. I am the executive director of the National Association of Social Workers New Hampshire chapter, also the executive director for the Vermont chapter. I am a social worker and I live in Pennacook. The social work compact, right now, when there's a social worker who's licensed in New Hampshire and their client goes out of state for any reason, travel, business, and they need to talk to them, because if they're only licensed in New Hampshire and they are not licensed in the state where their client now is, in order to see their client through telehealth is illegal. They're not licensed in the state where their client is. What this compact does, as others have explained, and as the same bill, Senate Bill 318, passed unanimously in the Senate, will do is not only save money for social workers, but also provide continuity of care for clients. Social workers right now in New Hampshire are oftentimes licensed in multiple states. They're licensed in Maine, Massachusetts, Vermont, other places, and that's expensive. Each time they're licensed, it costs to get licensed, and then the continuing education and relicensure every 2 years. For continuity of care, social workers often have clients who go to other states for some reason. They have clients who decide to go somewhere warm during the winter. If they're not licensed in any of those warmer states, they can no longer continue to see their clients. If their client is going off to college and they're not licensed in the state where their younger client is, they can no longer continue to see them. And vice versa. We have, in thinking about workforce issues, if a student from Vermont goes to UNH and they are seeing their social worker in Vermont, and they come to New Hampshire, if their social worker from Vermont is not licensed in New Hampshire, that student is going to need to find a new therapist, a new clinician. That's one more spot that's taken away that could have been better, and that client probably would have been better served by their current social worker. You've heard lots of different reasons for this, but Senator Prentice, you're correct. There are 6 states that have right now enacted the law. One more, and the commission can start. We do want for New Hampshire to be an early adopter, because then we've got a seat at the table with Director Courtney. They're representing New Hampshire, where all the big important decisions like data systems and rules get made. So that's my testimony, and I'm happy to answer any questions that you might have.
Any questions from the committee? I actually do. Do you know what this other 6 states are?
Virginia, Kentucky, Utah. Sorry, I'm looking at the map in my head. South Dakota and Washington State.
Oh. Okay.
We're this close in Vermont.
Okay.
Maine is very close. I believe Rhode Island is very close. I'm not sure about Connecticut.
Okay.
Massachusetts will take a while.
All right.
Oh, no, they're not. They are not.
All right. Any other questions from the committee? See, oh, well, actually, I do. Let's just say in the example that you gave, where Vermont resident went to school at UNH, and let's say Vermont had passed it, could that, and the therapist was in Vermont, could that New Hampshire student receive?
Yes.
Okay.
If both New Hampshire and Vermont are part of the compact, and the social worker in Vermont has their interstate license, right? It'll be the same process, just a special designation that will allow them to do that. But that's all the rules that the commission will establish how that all works out. So their client in Vermont now is in New Hampshire for school. They will be able to continue the the therapeutic relationship.
But if, let's just say New Hampshire hasn't passed it yet, but Vermont did, would that, still that student be able to get services? So they
Only if the social worker is licensed in if New Hampshire is not a part of the compact, the Vermont social worker would need to be licensed in New Hampshire to continue seeing their client.
So the person who's receiving the services has to be in a state. So there's two components to it. The individual who's receiving the services has to be in a state in the that's in the compact, and the therapist has to be. Okay.
You're correct. Yes.
Okay. Any other questions from the committee? Seeing none. Thank you.
Wonderful. Thank you.
CM Hawkins.
Good morning, Madam Chair, members of the committee. I will keep my comments brief as you've heard fantastic testimony from the experts behind me. My name is Sam Hawkins. I'm the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI, I'm here today to speak in support of House Bill 1190. You've heard great reference to the workforce shortages continuing to challenge our state, especially the mental health care workforce challenges. But it's important to note that the average delay between the onset of mental illness symptoms and treatment is 11 years. We know that when individuals with mental illness receive the right services at the right place at the right time, fewer folks will end up homeless, hospitalized, and/or incarcerated. We've heard about the importance of continuity of care, whether it be for students moving out of state for college, military members and their families being stationed in another state, other forms of relocation that is often temporary. Think of someone who's going to visit family out of state for 2 weeks for the holidays, and they want to maintain that relationship, keep their session, but they can't. Being able to maintain that therapeutic relationship without the unnecessary gaps in treatment is essential to an individual's recovery. This bill would help to address the mental health workforce shortage in our state, expand access to care for granite staters in need, and enable continuity of care for existing patients. We applaud the actions of the Senate in passing Senate Bill 318, and we ask that you recommend this bill ought to pass. Thank you very much.
Thank you, Sam. Any questions from the committee? Seeing none.
Thank you.
Thanks. Right now, I have the last speaker, Bethany.
Hi, Bethany Cottrell. I have a letter here from Director Courtney. Bethany Cottrell, I'm the Division Director at OPLC. Thank you so much for hearing my testimony today. So OPLC is in support of Bill 1190, and there is a letter being passed out that is signed by Director Courtney. She's sorry she could not be here today. There's 4 places I think we need to be in this building at once this morning. So you have heard testimony from the others that is very much in line with where OPLC stands on this bill. The other pieces that I just would like to bring to your attention regarding the public protection is that by entering into an interstate compact with the multi-state license, there is a database of all of these licensees that we will have access to if there is any complaints or actions taken against any of these licensees. There's a requirement within this compact that has to be reported to the home state and also a ability to have their license suspended or revoked in those other states as well. So unlike the unlike the endorsement, licensure by endorsement, where we don't have that database and that ease of communication, this does allow for that piece of it and adds that extra level of public protection. And then the other piece is the standards across the states. So like it has been said that this has to be done in one way. It's the same language in every state. It's the same requirements. We have been working very closely with the compact to help draft that. And once this gets passed, we would like to continue that work and we'll maintain that. And so it will allow us to say that our standards are the same standards as every other state in this compact as well.
Thank you, Bethany. Any questions from the committee? I should have asked the representative this, but do you know what the Senate bill number was and who the prime sponsor was?
Senator Pearl.
Oh. 318.
Thank you.
Okay. Senator Prentice.
Thank you, Senator Birdsell. Good morning, and thank you
Good morning.
for joining us. And I think I'm good with this, but I think for clarity, since you brought up like the coordinated database and adverse actions in a home state, which has control of a license. So if somebody has a licensure action from another state, us being the state that they would be coming to practice in, we can look into that. We can make a decision whether we want to honor that multi-state license here or not. I think it's, just an important protection to be on the record for.
Correct. Yes.
Good. Thank you.
You're welcome.
Beautiful.
Any other questions? Seeing none? Thank you.
Great. Thank you so much.
Is there anyone here that did not sign up for, to speak on House Bill 1190 but wants the opportunity? With that, I'll close the hearing on 1190. And one thing, if I could ask the individuals, once the hearing starts, please don't block the door or stand near the door. All right, I am going to begin the hearing on House Bill 1296 relative to coverage for diagnostic and supplemental breast exams. And I invite the prime sponsor. Representative Rombo.
Yes. Good morning.
Good morning. Welcome.
Thank you. Good morning, Madam Chair and honorable members of the committee. I am Representative Catherine Rombo, Hillsborough County District 2, Town of Bedford. I'm here to introduce HB 1296, which relates to insurance coverage for diagnostic and supplemental breast examinations.
Can I make sure that no one's blocking the door, please?
Thanks. In short, this bill seeks to increase earlier detection of breast cancer by eliminating patient cost sharing for medically necessary supplemental imaging and examination costs that deter patients from seeking follow-up and diagnostic care. The bill recently passed the House Commerce and Consumer Affairs Committee on a unanimous vote and then passed the House on the consent calendar by voice vote. And I mention that not to suggest that would impact your analysis here, but I thought it was an indicator of how collectively the committee felt it was an important bill with minimal financial impacts, but real impact for families, as we can talk about in a moment. As you may already be aware, getting a mammogram is only an initial step and is not able alone to diagnose cancer. Early detection of breast cancer is not possible without the medically necessary diagnostic follow-up or additional supplemental imaging required to rule out breast cancer or to confirm the need for a biopsy. So while mammograms are widely covered by insurance without patient cost sharing, some individuals at higher risk of breast cancer or those requiring follow-up imaging due to an abnormal mammogram result can face hundreds to thousands of dollars in further costs before even potentially being diagnosed with breast cancer. So an estimated 12 to 16% of women screened for a mammography require follow-up diagnostic imaging. I know some of us in this room have supported wives and daughters, sisters, mothers through this journey. Some of us may have lived through breast cancer ourselves. It's my hope that with this legislation, more women will not let financial barriers delay an early diagnosis of breast cancer and further delay treatment options. By detecting breast cancer early, these exams can save lives and reduce the need for more invasive and expensive treatments. I have a few statistics I would like to share with you all. It's estimated that 40% of women in the U.S. have dense breast tissue, and this dense tissue makes it more difficult to breast cancer through mammograms. Average out-of-pocket costs for diagnostic imaging examinations range from $234 to $1,021. In 2023 alone, more than 1,390 individuals were diagnosed with breast cancer and more than 180 died of the disease in New Hampshire. We have the fourth highest rate of breast cancer in the country. Research suggests that when women with dense breast tissue do not receive supplemental breast exams, up to 1/3 of breast cancer diagnoses can be missed. The longer it takes for women to detect breast cancer, the quicker their 5-year survival rates decline. The Massachusetts legislature recently ordered an independent study by the Center for Health Information and Analysis, which found that eliminating out-of-pocket costs might result in only a slight increase in members' premiums of between 19 cents and 33 cents per member per month over 5 years. And similar legislation has already passed in 20 other states, including Connecticut, Maine, Maryland, Oklahoma, Texas, Georgia, Missouri, and Washington, and is pending in Massachusetts, New Hampshire, and Rhode Island. I'd also like to emphasize that this bill has no fiscal note, and the New Hampshire Insurance Department Commissioner Betancourt stated in correspondence that this bill will not defray state costs. The bill does not apply to state health benefit plans, and Medicaid already provides these diagnostic exams at no cost to patients. So I know you're considering many bills. I appreciate your attention today. I asked for the committee to vote to pass on HB 1296. It really has minimal financial impact and has huge impact on families and communities. And I'm happy to take any questions, and then I believe we have some others to speak after me.
Thank you, Representative. Any questions from the committee?
Just if I may, real quick.
Yes.
So basically what you're saying is if somebody has a breast exam and the doctor or the physician isn't really sure because of a blurriness, the follow-up is not covered?
There's more patient cost sharing. Right now, your mammogram is covered. Generally, under the Affordable Care Act, your mammogram is covered. But if you need that addition to your 16%, if you need follow-up, you can be paying a sort of sliding scale of cost.
So all callbacks are not covered?
Correct. And I mentioned the number because there was concern in the House committee about the cost, and it's a smaller pool of people we're talking that need this follow-up, but it can be a big deterrent to them to make those appointments and follow through. Unfortunately, we had a testimony in the last hearing in the House committee with Dr. Eva Leiser, who does breast screening, and she is not able to be here today because the power outage last week backed up so many of her patients who are many of them doing follow-up imaging, but she spoke really eloquently about patients who come in and waited months after initial, and they're much sicker.
Would you believe my wife does this for a living?
Oh, okay. Well, there you go.
So
Then I'm
I get a
preaching
lot
the
of shop
choir.
talk.
Yeah.
Yeah.
Okay.
Thank you for bringing this bill.
Any other questions from the committee? I do have one. If they have to come in for a follow-up, I know you said it was a sliding scale. Or if there's someone behind you that knows, what would be the minimum and the maximum that the patient would?
The number that I have is that the average out-of-pocket cost for the patient is from $234 to $1,021.
Wow. Thank you.
You're welcome.
Any other questions? Seeing none.
Okay, thank you.
Representative Tim McGow? Welcome.
Thank you, Madam Chair. It's nice to see Representative Tim McGew from Merrimack here, not only for a family member who recently survived triple negative, late life diagnosis of triple negative breast cancer that was caught on a supplemental breast exam, but also here for the House Commerce Committee. The second time I've appeared here on a breast exam bill in, I think, about 30 years. The last time was in 1996. It's a rare occurrence that a mandate like this makes it out of the House Commerce Committee. I think you probably know that. And the last time was under the same chairman, and it had to do with well, fortunately, this supplemental exam caught a family member's triple negative diagnosis, and she's 3 years now, survived. So anyhow, I urge you to pass this bill because it'll do a lot of good. As you know, we're ahead of the curve in New Hampshire for breast cancer. And the idea of this bill is to cover this type of exam, and will help a lot of people. So I'll keep my testimony quite brief on that. And I've got a couple other bills to talk to you about. And it's great to see my former bureau chief and talk to you about a few EMS bills in the coming minutes. So that's all I have to talk to you about. Thanks.
Any questions from the committee? Seeing none, thank you, Representative. Michelle Heaton.
Good morning. I'm Michelle Heaton. Sorry. I'm the Director of Life and Health at the New Hampshire Insurance Department. The department takes no position on this bill, but there are some things that I'd like to clarify. The bill is to eliminate cost sharing. These services, whether diagnostic or preventative, are already covered under all insurance, and this is not necessarily a coverage issue. Instead, this is intended to remove cost sharing to make it more affordable for people to get this follow-up care. So under the ACA and essential health benefits, all preventative screenings have to be provided without cost sharing. So what this bill is intending to do is make it so if there is additional testing that's required for diagnostic purposes, that would also be waived for the participants. So there would be no cost sharing for that. It's very difficult to do a mandate study on this type of thing because, again, for one, it's not mandating any new care. This care is already being provided. Instead, we're talking about shifting the cost of that care. And it's very difficult to do for these types of mandates related to cost sharing because the amount of cost sharing that a person may be responsible for is highly dependent on the plan that they have. Whether they have high cost sharing limits, high deductible, or if they have lower cost sharing, lower deductibles. On top of that, if someone were to go receive this care towards the end of the year after they've already met their out-of-pocket maxes or they've already met their deductible, then they're not going to have any cost sharing for this specific service. So given all of those different things that are highly dependent on the individual and the care that they're receiving, it's very hard to estimate what fiscal impact this could have on premiums. That being said, we did the best we could. We did do some claims analysis, and we saw that for the most part, these services are provided in New Hampshire without cost sharing. However, there is a very small portion of those services that are subject to cost sharing, and I believe on our analysis, that cost sharing was around $100. But again, that can vary for many reasons. If someone's already met their cost sharing max or deductible for the year, then they're not paying that higher amount that potentially they could if they had this service done in January before they've met any of those things. So I'm happy to answer any questions.
Any questions from the committee? Seeing none. Thank you, Michelle. Mike Rollo.
For the record, Mike Rollo, American Cancer Society Cancer Action Network. I don't know how long I'll actually have, I don't know if I'll need them for long, actually. But we are obviously here in support of House Bill 1296. I think Representative McHugh from the Commerce Committee put it better than I can. It's not easy to get a bill like this through the House Commerce Committee, especially unanimously. We would see this as a win-win for the state and for those that need to be screened. We know that costs are can be a barrier for people getting screened, and the sponsor also already let you know that in New Hampshire this year it's estimated that 1,460 women will be diagnosed with breast cancer. And unfortunately, 180 women will lose their battle with the disease this year. And we would like to do everything we can to help lower that number. And if we can remove any additional barriers to folks getting screened, Senator, no, sorry, not Representative, Senator Avard and I have discussed this previously when we were discussing a different bill. But my wife, some of you know her, but when she goes for her annual exam, because her family has a history of breast cancer, she is this person. She has no problem with me sharing this story. She has to go for a follow-up exam every single time she goes because she has dense breast tissue. And normally it's, she goes for a follow-up ultrasound and they just clear her. And this time around, they found something. And, then she has to go back for another round and, wait the terrifying amount of time and cut to the chase. It was just a cyst. She's fine. But, we're very blessed that we have exceptionally good insurance. We don't have to worry about out-of-pocket cost sharing, but we're not every family in the state of New Hampshire. We're blessed, but not every family can, has our type of insurance, and not everyone maybe be able to afford up to 100, or as the study that the sponsor had mentioned, is anywhere from $234 to up to $1,021 is what one study showed. And there's other people that want to testify. I know you're way behind this morning, but we would ask you to seriously consider giving a positive recommendation to House Bill 1296, and I'm happy to answer any questions you may have.
Thank you, Mike. Any questions from the committee? Seeing none.
Thank you very much.
Thank you. Heidi Kroll?
Good morning, Madam Chairman and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm here today representing AHIP. I did sign in opposition. It's at a very high level. It's not necessarily specific to this particular mandate, but I think just some words of caution, I guess. So first of all, just to be clear about which type of insurance would be impacted by this. So it's just going to be the fully insured employer-sponsored insurance. So it does not apply, obviously, to Medicaid or Medicare, not to any self-funded plans, including the state employee and retiree plan. It also, it's not applying to the individual market because presumably there would be a cost to the state as the insurance department mentioned. There's no defrayal cost. And there's also a provision in here that carves out anybody who has a high deductible health plan. We need to be sure that we're not running kind of afoul of IRS provisions around high deductible health plans. So that is carved out as well. So I just wanted to, first of all, be clear. This is who this applies to and who it doesn't apply to. I will say that, and what I passed out is an article that recently appeared in the Business New Hampshire magazine. It's called "Small Businesses Face Higher Health Insurance Premiums," and I just want to kind of caution the Senate around the cost shifting, which the insurance department did mention. The costs don't go away. The costs are simply going to be shifted into either premiums paid by the businesses or other cost sharing or higher deductibles. I know that the costs in this particular mandate have been estimated, somewhere around maybe 20 to 30 cents per member per month. Please keep in mind that in the aggregate with all of the mandates and requirements that get passed in any typical legislative session, those add up. And so I just kind of wanted to caution that I think we just I understand the issue at hand, and we don't want financial barriers to folks getting care. Carriers want people to get care as well, but just wanted to kind of flag that I think you will probably see other requests in the future for other from other advocates looking to get cost sharing waived on other services as well, and just to keep in mind that the costs don't go away; they just get shifted elsewhere. And I think with that, I'm just happy to answer any questions.
Thank you, Heidi. Any questions from the committee? Or Bradley?
Thank you, Madam Chair. So this might be a question also asked of the representative from the insurance department, but when you make diagnostic care more readily available, when the analysis gets done of the per member per month cost, does it factor in early diagnosis leading to lower cost outcomes, surgery, chemo, radiation, all of that? I mean, does that
So
get taken into account?
I think those would be savings. You're exactly right. And we don't disagree with that. There would be savings over time. And I think what you heard from the insurance department is that the cost sharing overall does appear to be pretty low looking at the claims data. So that's kind of already, that's one reason why the cost estimate for this is not high, not too high anyway. And yes, I think there's a recognition. So I don't disagree with any of that. I just wanted to flag that that the costs don't go away. They do get moved around. So
Any other questions? Seeing none? Thank you, Heidi.
thank you.
Carney Becker? Carrie, sorry.
I'm Carrie Becker. I am, thank you so much, Madam Chairman, and the rest of the committee for allowing me to speak today. I live in Northampton. I am the mom of two very active boys, and I'm extremely active in my community. I am on the board of my local running club. I'm also on the board of a youth sports organization, and I work with a national running club too. I'm sitting here today talking to you as a breast cancer survivor. I was diagnosed in February of 2021 at the young age of 46. I'd like to ask for your support for House Bill 1296. I believe that we need to protect women, and I'm going to clump it in with women because I know men also get breast cancer, but it's 1 in 8 that women end up with breast cancer. As people have mentioned earlier, the Affordable Care Act does cover your initial mammogram, but if you have an abnormal mammogram, meaning there is something funky that shows up on that screen, you have to have diagnostic testing. And the diagnostic costs can be expensive, let alone the journey to go through it. I mean, imagine if you have a sister, a mom, or yourself, or a wife who has to go through and all of a sudden their mammogram is abnormal. There's that fear. Oh no, what is this? What's going on? What do I have to do? I have to go take care of it. During my annual mammogram in 2021, there was an abnormality. And before my unilateral mastectomy, I had so many diagnostic screenings. I had 3 mammograms, 3 ultrasounds, 3 biopsies, 1 MRI, blood screening to see if I had the BRCA genes or any other genes, and I met with 10 different specialists. So adding up to that, that's expensive. Luckily and fortunately, my husband and I were able to afford the deductible on the out-of-pocket costs. If we go and we all agree that women are caretakers, they spend their time taking care of family members, taking care of aging parents, children, and a lot of times having to be a dual income family, it's hard to take time off from work to go and have these diagnostic screenings or to set aside the money that it's going to take to pay off the deductibles. Because a lot of times we don't have the option or the choice on what insurance plan is offered to us via our jobs, correct? Rather than pay for the diagnostic screenings, a lot of women will sit and take care of their families or caretake. And in the long run, they end up with putting their health in jeopardy. I know a woman who decided that she didn't want to have the diagnostic testing because it was going to be too much. And instead, she wanted to pay for her son to go to college. Unfortunately, she has passed. She didn't survive. She didn't go. There's that 1 in 8 chance. Am I that 8? Am I that 1 in 8? Or am I just, something funky that showed up on the screening? We never know. If we take the emotional piece out of it and we think about, I don't know, let's put it in perspective of a small pizza shop in New Hampshire. It's the cornerstone of the community. People go there after football, hockey games, or the town rec team goes and celebrates their season. The kids hang out there because it's a safe place to go. It's good food. It's family owned, family run. The wife ends up with an abnormal mammogram. She cannot afford to pay for the diagnostic screening, whether it's they're uninsured or their health plan is such a high deductible. So she puts it off. She gets sick. And by the time she goes in, it's harder. She's one of those 1 in 8. So it is going to cost more. Maybe it puts the pizza shop out of business. Then the cornerstone of the community is gone. It would be great if cost sharing wasn't there so that we could show the value of what a woman has and the diagnostic piece to it. My husband is a small business owner. His company is based out of Bedford, New Hampshire. In the past 5 years, they've had 5 people diagnosed with breast cancer. Premiums increased quite a bit. They decided to absorb those increases and not pass it on to the employees because they feel that is much more important to put the money into their employees, their spouses, their significant others, and allow those people, the women, to get the healthcare they need, the diagnostic testing, and then they're making money. They're not making less money because they're not having to pay as much for the premium increases, and then they're spending money in the economy. We want the economy to flourish. We want money to go back in it. So if we want money to go back in it, then we need to help with the diagnostic costs and the cost sharing. I love New Hampshire. I think it's fantastic. I think it's important. I think we need to support women, and I think we need to sit there and say, all right, we see value. Yes, this is scary. Yes, you may not be that 1 in 8, but hey, let's double check and make sure. I'm a firm believer that preventative health care goes a lot further than quote unquote sick care. So if you're sick and you're trying to get ahead of a cancer diagnostic or breast cancer diagnosis, you're spending a lot more money. You're not being part of the community. You're not putting money back into the economy per se and building up things. That's just my personal opinion. And I'm just asking you as a breast cancer survivor to really think about it and support the bill.
Thank you, Carrie. Have a question? We lost everybody to,
I have a prime sponsor bill at 10 o'clock.
we all do.
And so I apologize. That was great testimony, but I have to leave.
Thank you so much. I'll leave it. I also have, if you want, some of the costs for the breast cancer imaging study that was done in Massachusetts. I can leave it.
That'd be
If you
great.
take it,
And then they'll
it's
make
fine.
copies of it. Thank you, Carrie.
I have
Oh, okay.
but I didn't copy the big one. That's the one. Angela. Yeah, but I have it. Thank you. Thank you.
Peter Bragdon. Welcome.
Well, thank you all for being here this morning. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's not-for-profit health insurance company. Here in, I guess, semi-opposition to the bill, not for the coverage side of it, and I'm glad that Michelle from the insurance department did correct something stated earlier. These services are covered. by, I think, all health plans and certainly all Harvard Pilgrim health plans. But there is a cost share involved, a cost share being either deductibles, copay, co-insurance. And so these are covered. And I think our opposition is not with respect to the services themselves. I think all the things stated earlier are true, right? Early detection saves lives, it saves costs. Financial barriers can interfere with early diagnosis. And the survival rate for those who are detected early is much better. Basically, the earlier detected, the better. So there's no argument with that. I would say that that's probably true for all cancers. And I think the two concerns that we would have is one, this is maybe the first step in a number of people. Next year, someone's going to come and want prostate cancer to waive the cost sharing for prostate cancer, waive the cost sharing for this, waive the cost sharing for that. This year already, there's been several bills that have passed through either the House or the Senate regarding waiving of cost share for various things. There's been a number of increased insurance mandates, which then and you've probably seen this before, the market described as a balloon. You squeeze one end of a balloon, the air doesn't escape into nowhere, it goes somewhere else. And in our case, there's only two places where those costs, if you take away the cost sharing here, those costs are going to get shifted somewhere else, either to premiums or to increased cost share for the members. And I will say this particular coverage mandate, I think the Department of the Massachusetts study that was just passed out is very good. So a couple of years ago, Massachusetts had a almost identical bill, I believe, and they actually hired, I think it was Barry Dunn, it might have been somebody else, but an actuarial firm to study the costs, and it came to about 19 to 33 cents per member per month. So it was not a huge amount of cost. So that's a good study. It kind of tells how they did the work. So it's not this particular one. I think it's the aggregate, but those costs are going to go somewhere, and our concern is, and what we see is, as those costs increase, on the aggregate mostly, then companies, let's say, are faced with two decisions: either stop providing health insurance for their employees, or more likely, go to a plan that has a higher cost share for the members. And maybe in a good world, that becomes a plan with a health savings account, which would be exempt from this bill anyways. But so what happens is people either have higher cost shares, thus they put off testing that should be done because of on other things, or they have to get their own insurance, and some may not. So as the pressures increase on the cost shifting, our fear is that people will have less insurance coverage on everything else, even though we pass individual items. So again, not opposed to the coverages themselves. It's something we provide, but just the big picture, the effect of cost shifting on people's ability to have insurance in the first place. And our goal is to see as many people with insurance as we can. So call that to your attention. Obviously, I think the bill, as you've been told, made it through the House Commerce Committee. That in itself, probably a small miracle, unanimous vote. Oh, well, 17-0, so 4 people were absent, but we'll assume they would have voted the same way too. So yeah, not opposed to the concept behind it, but I think we are concerned about the big picture of all the pressures on health insurance costs this session. Happy to answer any questions from the numerous senators at the table.
Thank you, Peter. No questions here.
Thank you.
Our last speaker is Deborah Hutchings.
I'll be quick. Excuse me. All right. Thank you so much for giving me some time today. Just a minute or two is all I need to speak on behalf of men and women who face the critical medical decisions that are needed when they're faced with a potential breast cancer diagnosis. My name's Deborah Hutchings. I live in Manchester, New Hampshire. I have 3 beautiful adult daughters, 6 amazing grandkids. I have worked for the past 24 years at United Health Group, but I'm not here on behalf of them. I'm here as a breast cancer survivor. I faithfully went every year for my preventative mammograms. In June of 2020, my mammogram was clean, nothing abnormal. 1 short year later, as you've heard from many people here today, something abnormal showed up on my preventative mammogram, and I needed those advanced diagnostic tests. My husband and I are fortunate that we were able to afford those diagnostic tests. I had to go to breast MRI, advanced imaging, all leading to my biopsy to find out that I had triple negative breast cancer, which is the most aggressive breast cancer there is, with limited treatment options. Through further testing, I learned that I was also BRCA2 positive, so it's genetic. And I have 3 adult daughters who then needed to get tested, and as a result, one of them is also BRCA2 positive. The advanced diagnostic testing results were widespread. My daughter now knows that she needs to get the advanced treatment and monitor her status. I spent the next 8 months going through chemo, immunotherapy, hospitalizations, multiple surgeries, and radiation. In March of 2022, I received PCR, which is pathologic complete response. The cancer was gone, and my body would never be the same as I lived with several effects from the treatments. And I'm so grateful for the medical teams at Elliott Hospital and Dartmouth-Hitchcock, my breast cancer surgeon, my oncology team. The cancer's gone. I don't know how I would have done it without my family and my husband's support. But through all of this, I became aware of other women who were forced to work during their chemo and their radiation because of financial reasons. I've learned the statistics that were already spoken to, so I won't go into those today. Of the women, 20% of women don't get that advanced diagnostic testing. My cancer was fast growing. In one short year, I had 2 tumors that metastasized to my lymph nodes in 1 year. If I had not got the advanced diagnostic testing, I would not be here today. I'm sure of it. Fortunately, my husband and I are financially able to take care of those costs, but so many women cannot. I think everyone in this room knows that if you needed that advanced diagnostic testing, you would not hesitate to move forward with it. But for people who have to decide between groceries or an advanced imaging test or paying their rent, or as someone mentioned early, college education, they choose not to go forward, and it's a life or death decision. So I continue on a diligent path of monitoring and surveillance so that early detection is there for me. Last week, for example, I had a CAT scan, and it was a $525 cost share for me. Fortunately, I'm able to do that. But what about the women who can't and choose not to get that CAT scan and let the cancer grow within their bodies? So on behalf of all of those who are struggling to afford life-saving breast cancer diagnostic testing and who need to make these hard decisions, I'm strongly urging you to pass 1296. It's a huge step in eliminating inequity in healthcare.
Thank you, Deborah. Any question from?
Thank you so much for
Thank
giving
you.
me your time. Appreciate it.
She was our last speaker. Is there anyone here that would like to speak on 1296 but not given the opportunity? We're behind. I appreciate it. So right now we have Ben Bradley not speaking in support, Lynn Courier Stanley not speaking in support, and John DeJoy supporting but not speaking. So with that, I will close the hearing on 1296 and we will move on. Is there a Chris here? Chris, I can't see the last name. Cody? Cordy? Maybe?
C-O-A-T-E-S.
I don't know, but I think so. You didn't check whether you wanted to speak or? No. Okay. You ready? Okay. All right, I will open the hearing on House Bill 1568 and invite the prime sponsor up, Representative Sellers. Welcome.
Thank you, Madam. Thank you, Madam Chair and Senate Committee. My name is Representative John Sellers. I'm Grafton District 18. I represent the 10 southern towns of Grafton County. My constituent brought this up to me to see if I would put in a bill to help out. Basically, this really comes down to cost and money. And every single one of our towns, they go out on these service calls and they don't know if they're going to transport a patient or not. And at that point there, if they don't transport, the town at that point is picking up the full cost because they have the manpower on call. They're actually giving out the Band-Aid. They might have 2, 3, 4, 6 people maybe helping out. It could be just as simple as a lift assist. Someone has fallen out of their chair and they can't get up, and they need people to help get those people up off the floor. All right, and so basically the towns are really coming out and saying, you know, this is costing every single property taxpayer money. And they're saying, they're thinking, and I think I agree with them at this point, and I put the bill in. And this bill is very similar to SB 409, which you've heard from the Senate side. And basically it's sharing the cost in this. Really, it's offsetting it to use the Medicaid, where, as you're well aware, I believe the state pays 10% and the federal government pays 90%. So therefore, it takes it off the property owner, all right, as far as taxation goes, to keep the cost of the ambulance and the cost of the service providers, the personnel ready and manned at that point. So my understanding is they call it the dry run calls, okay? These are calls that don't get transported. And they're saying they could be as high as 55% of all calls that they do. All right. As I said before, 409, which I've already heard, passed here on a voice vote, or passed on a voice vote, is actually being heard from the House side today, upstairs. And I'm just trying to think if there's anything else I can really share. I can definitely share that my wife's, who is an advanced EMT, and I get to hear some of the calls from time to time. The calls and where they are, they're public. As far as what happens during the calls, I don't know. But I do understand that many of the calls don't get transported. And the only time the company gets reimbursed is on a transport call. So this really does help the taxpayers directly, and it offsets some of the money over into Medicaid. I don't really have any more to add, so I'll take any questions if you like.
No questions? Seeing none. Thank you.
Thank you.
Representative Tim Magoo.
Hello again, Representative Tim McHugh from Merrimack. Longtime member of the EMS community. Well, I'm not actively working as a medic. I am actively still licensed. So this is a simpler version of Senate Bill 409. This version passed the House with a 101 vote margin. And I would encourage this committee to amend it as you see fit. But the idea behind this bill is to provide some reimbursement for those non-transport calls where non-transport benefits both parties, keeps the patient at home as opposed to transporting the patient and overcrowds the already taxed ERs. So the scenario here is potentially, it's a very small number of patients where the EMS service has a duty to respond. You know, somebody calls 911 or calls for EMS, and the service responds and potentially does a fairly elaborate ALS workup. So it's a small percentage of patients, maybe 5-10% of responses. And the classic scenario, the classic example that Senator Prentice could certainly understand, certainly relate to, is an advanced life support workup, maybe a semi-conscious or unconscious diabetic patient that has an IV started and ECG done, oxygen applied, maybe even medication administered like dextrose or something for a diabetic patient. And that patient wakes up and no longer needs transport and potentially refuses transport, which is potentially fine, safe, and a responsible thing to do. And every paramedic has been through this scenario. But a significant expense and significant time has been spent. But it's responsible to leave that patient at home as opposed to take them needlessly to the ER. But that service is incented to transport them simply to gain reimbursement. This bill would allow for reimbursement for those Medicaid patients. So it's a fairly small number of patients. And Senate Bill 409 is a slightly more complex version of this bill because there's more criteria that need to be satisfied, has to be a 911 call, and there's other criteria that needs to be met. And this is a little broader. Anyway, so that's pretty much what the bill does. There's the 409 addresses resuscitative efforts. So scenarios where you might have a full resuscitation and then non-transport or leave that deceased patient on scene after doing a full resuscitation, which is another scenario where you might expend a lot of resources and not transport also. So there's some other folks that will testify based on other scenarios too. So anyhow, makes sense. Good bill, common sense. Urge you to pass it like we did in the House. So
Thank you,
thanks.
Representative. Any questions? Seeing none. Thank you. Representative Proof. Okay. All right. Rob Berry. Welcome.
Good morning, Madam Chair, member of the committee. My name is Rob Berry, General Counsel of the Division of Medicaid for the Department of Health and Human Services. We support this bill. We testified at the House during the House public hearing that this bill should be aligned with SB 409. We felt the parameters in SB 409 were important from a CMS perspective in terms of outlining how the program would work. And we also suggested the contingency language in terms of whether, if CMS did not approve it, that the department would not be held responsible for implementing the program. The only thing that remains outstanding is Director Lippman had testified that we do anticipate we'll need an appropriation to implement this. And that's the only other thing we would ask for at this point in time. But as Director Lippman testified on SB 409, this is a worthwhile policy to pursue, and the department's in support of it. And I'm happy to take any questions.
Do you know if, and forgive me, we've had a lot of bills since 409. Do you remember what the appropriation, did we assign an appropriation?
You did not assign an appropriation to SB 409. That's the only outstanding item. Otherwise, SB 409, from the department's perspective, looks great from an implementation.
Do you think there will be an appropriation by the time it hits the House hearing?
I'm not quite sure. The House hearing is going on as we speak. So as soon as we're done here, I'm going to run right up there and say the exact same thing.
Okay. All right. Thank you. Any other questions? Okay, seeing none. Thank you.
Good morning, Chris Stewart, Hollis, New Hampshire Ambulance Association. I would just echo what all the previous speakers have said, that we would, I think, support the language in 409 a little bit more. It's more of a roadmap for reimbursement, and as well, just to note that some of the commercial providers are already paying this benefit to people that are in network. So it is a common practice and a spreading one across the country, and we think it would be wise to take away the incentive to transport somebody who doesn't need to be transported just to gain reimbursement. Thank you.
Thank you, Chris. Any questions? No? Okay. Thank you. That is all those that wanted to speak. Is there anyone here that would like to speak on HB 1568 but was not given the opportunity? With that, I will close the hearing on HB 1568.
Yeah, I think I signed in to speak on it for him anyhow. So this bill came through Commerce as well, and I think it was one of the other ones that we passed out unanimously. It's a common sense bill. So this bill allows for direct payment to the ambulance providers and just prevents folks from remodeling their bathrooms with the reimbursement that they receive from their insurance companies for ambulance bills. So, it's akin to when you file an insurance claim for an accident for your car insurance. Oh, Representative Prue, well, I'll happy to cede the mic to the prime sponsor. Sure. So you get the idea. You have an ambulance bill and the insurance company sends you the check directly and you deposit it, and then the ambulance company never sees the money. And that's often what happens. And we saw testimony, we saw evidence, we saw checks that never made it to the provider. And this allows for direct payment directly to the provider. And so it's common sense, and that's why we passed it. So thanks.
Morning. Representative Mark Prue, Hillsborough 15, Manchester Ward 8. I'm not sure exactly what the representative said, but I caught most of it. And yes, this just simplifies the service getting paid, keeps the middleman out. We actually heard some testimony. One of the representatives in Commerce has been taken the ambulance a couple of times. First time she received the check and said, "What is this? Why is it coming here?" Didn't really know where to send it. Eventually figured it out. Second time, she mailed it to the wrong ambulance because a different ambulance took her the second time. So she said, this is crazy. It should just be taken care of. In my town, we have people that tend to use this as a second form of income. We used to have one frequent flyer that you could always know when rent was coming due. He would take a ride to the hospital. He would be walking out the hospital door before we could finish the paperwork and make up the stretcher. He would get the check, cash it. We would never see it. And he was one of those guys that didn't care if he went to collections or whatever. So getting the check directly to us takes them out of the loop, makes it easier for the patient. I know one of the insurance companies say they want it to bring us into network. We're not coming into network. We can't afford to be in their network. We won't make enough money. So we ask that you change the language so the check comes to us. It just makes it simpler. Any questions, thoughts,
Any
comments?
questions from the committee? Seeing none?
Thank you.
Michelle Heaton. Welcome.
Hello, Michelle Heaton. I'm the Director of Life and Health at the New Hampshire Insurance Department. The department is neutral on this. However, we'd like to provide some information. This bill is directed, it's related to the idea of ground ambulance and balance billing. So currently under the statute, if an out-of-network ambulance provider provides services, these are covered services, and the insurance company is directed, they can either directly pay the provider or they can pay their member, and on that check it has to be payable to the member and the ambulance provider. The reason why it would go to the member instead of the provider is because this is for out-of-network ambulance providers. The carriers have no contractual relationship with these providers, and therefore they don't have mechanisms set up to facilitate quick payment like you would with in-network providers. The underlying issue here kind of relates to the idea of balance billing. So the No Surprises Act, federal law that passed, prohibits balance billing in every instance except ground, well, not every instance, but in covered instances except for ground ambulance. Ground ambulance was specifically carved out. So, I mean, I think a lot of the testimony and some of the stuff you hear is about, you know, these large bills, people not getting paid enough. This bill does not address how much money is getting paid. It does not prevent balance billing. It does not require any specific payment be made when these services are offered. So none of those issues are addressed. The department, starting last summer and through the fall, engaged in the ambulance summit. Coming out of that was our ambulance summit report that is now available on our website, nh.gov/insurance. If you go to reports, it's, I think, the first one up there now. And it has a lot more detail about all of the issues regarding ground ambulance, the need for funding, balance billing, and we also put in recommendations. It's the department's recommendation that we address this issue as a whole and not take out certain aspects of it and address it separately. I think there's a lot of stakeholders here. There's a lot of competing interests, and it's the department's recommendation that you address that entire issue of ground ambulance as a whole and not pull out specific things. This would be one of the specific things that would, this bill is a specific thing that they're trying to pull out regarding direct pay. So there's a lot going on here, and I'm happy to answer any questions.
Any questions?
Nope.
Okay, thank you. And Representative, you know better than to stand in the doorway.
Number 8.
You can come over here. Chief Mike Starr, welcome. Welcome.
Good morning, Senator. Thank you for letting me speak this morning. My name's Mike Setar. I'm the chief of the Tilton Northfield Fire District, but I'm here today representing the New Hampshire Association of Fire Chiefs in support of HB 1081. Listening to the previous speaker, yes, there are a lot of issues that need to be addressed with the ambulance billing, but in this bill specifically addresses one of the major concerns of the New Hampshire Association of Fire Chiefs, where we're trying just to take the middleman or the patient out of the process, because it's very confusing for them when they receive a check for a service that we provided and they don't know what to do with it half the time. As Mr. Prue has related, some of our clients have been using this form of payment to them from the insurance companies as another form of revenue for them. And I don't think that's really fair for the taxpayers to supplement an EMS service and then use the insurance payment to them to enhance their income on the backs of the other taxpayers within the community that are providing the service, the ambulance service. So it only makes sense that this passes. It's common sense, and there are many other bills floating around both on the Senate and the House side that are addressing other factors of ambulance ground billing. But this seems like to be a very easy one to address and fix one of the problems at any rate. My testimony will be I'll hand it out to you. I don't want to go over the whole thing. It's very wordy, but I'm happy to answer any questions.
Thank you, Chief. Any questions from the committee? Seeing none. If you could just hand them a copy of it and they'll make copies for us.
Thank you.
Thank you. Kathy Bizarro Thurvich. Welcome.
Well, good morning. Morning, Madam Chair, members of the committee. My name is Kathy Bizarro Thunberg. I'm the Executive Vice President, New Hampshire Hospital Association, representing all 26 of the state's community hospitals as well as our specialty hospitals. The Hospital Association supports House Bill 1081 relative to insurance payments to ambulance providers. The issue is familiar to this committee as Senate Bill 407 relative to direct pay for ambulance services recently passed this committee 5-0 and the full Senate on consent calendar by voice vote. Well, although not exactly the same language, both bills intend to address direct pay practices for ambulance providers. The current reimbursement model poses challenges for both the ambulance providers and patients, and we support all efforts to address this important issue. Supporting direct pay ambulance services aligns with the broader goal of enhancing the sustainability of emergency medical services. Adequate reimbursement is crucial to maintaining the availability and quality of ambulance services, ensuring that our communities and our hospitals who depend on them continue to receive the best possible care during emergencies. We would encourage the legislature to reconcile both House Bill 1081 and Senate Bill 407 to strengthen the language to be enacted into law. I urge you to support this bill. Happy to answer any questions.
Thank you, Kathy. Any questions from the committee? Seeing none.
Thank you.
Chris, welcome back.
Thank you for the opportunity. I'll make it simple. Well, we concur with the New Hampshire Hospital Association in full and support reconciliation of those two bills to come to an agreement. Thank you.
Schweiger, that's German. You pronounce the second letter.
Thank you, Madam Chairman, members of the committee. I'm Roy Schweiger from Concord, and I particularly noted two things that previous speakers have said. One is about when the checks were issued, they were in the name of both the individual and the ambulance company. So I'm not quite sure how this person is cashing the checks and using them, fraudulently without the ambulance provider having to sign it. And the second thing is somebody saying, well, they take their ambulance payment and use it to redo their bathroom. Well, that's my concern today. And I'm more in line with the insurance department that someone I know during the COVID pandemic, you were told to go to Concord Orthopedics if you had an orthopedic problem rather than to the emergency room. So they went to Concord Orthopedics. Concord Orthopedics said, no, this is, too much. We can't handle it. You have to go to the emergency room after all. And this person had walked into Concord Orthopedics, but they called an ambulance to take him to the emergency room, which, if you're familiar with Concord, is directly across the street from Concord Orthopedics. This person got a bill of $2,000 for that trip, which, that's less than a quarter mile if you drive the ambulance in a circle. It's less if you walk. They probably could have walked it in less time than it took waiting for the ambulance. But that's $8,000 a mile. And that's just outrageous. So I think that, and then the provider will not bill the insurance company, which says it's supposed to provide, Department of Labor rule this is a workers' comp issue, but the insurance company will not bill the ambulance provider is not billing the insurance company because obviously they won't pay $2,000. They're trying to get it out of this person. And I wish I could have got a copy of that bill to show you, but I guess it's confidential, it's private information, but if any of these providers claim that's not true, I can provide a copy of that bill. All they have to do is promise to pay it if it is true. So anyway, that's my feeling is this needs to be more comprehensive. We need to deal with that ground ambulance balance billing. And one thing that really upset me is somebody proposed an amendment to the bill that they would be reimbursed at 325% of the Medicare rate. I mean, I understand the Medicare rate, was low. It might be 60 or 80%, but, reimbursing at 325% of the Medicare rate is just price gouging. So I hope you'll, take this thing up as a, complete issue and deal with the fact that this is just like the emergency room. That, if someone needs care urgently, it's not fair to gouge them on the price. And if an ambulance service only wants to provide transport and not do emergency care, that's fine. But they shouldn't be doing emergency care and then doing price gouging. Thank you.
I know you want to speak again, but we are running behind. Oh, I'm sorry. Okay. They're all starting to blend together. Sorry.
Thank you, Madam Chairman. For the members of the committee, I didn't sign up, so thank you for allowing me to speak. I'll be very brief. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I represent AHIP. I just wanted to say that one of the things I just wanted to point out, and you hear me say this a lot in terms of what markets are impacted by this bill. So again, this is direct pay. This would apply to the individual markets and the employer group markets. So it's not going to apply to self-funded plans, obviously not applying to Medicaid, Medicare, uninsured, other categories. We learned during the ambulance summit that the insurance department held that something less than 10% of the payer mix of the ambulance providers is the fully insured market. So I just wanted to put that into perspective, that what we learned during that is the wide majority of their payer mix is either Medicaid or Medicare. And probably about another 10% is the self-funded market. So I did want to point that out. We don't have a particular concern with the direct pay provision. As was mentioned, this was also a provision in SB 409. We do have very serious concerns with the other provision in SB 409, which is the rate setting provisions that have been established there, where municipalities are allowed to set the charges and carriers would be required to pay those charges, or 325% of Medicare, whichever is less, when you look at data that the insurance department has in their report, you will see the carriers have been paying around, on average, depending on the billing code, somewhere in the neighborhood of 125 to maybe 160% of Medicare. That information in the report, which I encourage you to look at, that's table 3, also has information about the ambulance provider's charges as a percentage of Medicare. And you will see there that their charges are often below 325% of Medicare. And so our concern with that provision that was added to SB 409 and has been considered here or recommended here that you reconcile the two bills, our concern is that 325% of Medicare, any ambulance or any municipalities or ambulances who have charges that are currently below 325% of Medicare will be increased up to 325% of Medicare. That is going to be a significant increase in costs. And again, that will be borne exclusively by the fully insured market. And so we don't have a problem with the direct pay, but we do have a concern with the other provision of SB 409, which actually didn't get a hearing because of the procedural way that those amendments were handled. So,
Any questions from the committee? Seeing none. Thank you. That was the last speaker on House Bill 1081. Is there anyone? Okay, come on down.
He was wondering how they could cash that check with both names on it. I have copies of checks that have one name on it, the patient's name. They are not coming through with both names. That's why they're able to cash those checks and do whatever they want with the money. They're not coming through like they said. So, and to the insurance company, they have no way to pay us. Our address is right on the invoice that we send them, so they can pay us. And they're not paying $125 either.
Thank you, Representative. That is the last speaker, and we have 4 people who are in support but didn't want to speak. So with that, I will close the hearing on House Bill 1081. And when Cam is ready, we will open the next hearing, last hearing. Oh, you want something?
So we're going to open up the hearing for HB 1155 and hear from the prime sponsor. How's that for timing? Welcome, Representative.
Thank you, Mr. Chair and committee members. For the record, I am Jose Cambrils, representative of Merrimack County District 4, serving the towns of Canterbury and Loudoun. I speak to you today as someone who has received a life-saving kidney transplant just 4 years ago. So I am very familiar with all aspects of the organ donation and the transplant process. House Bill 1155, the Living Donor Protection Act, is a common sense bipartisan bill. As its name implies, this law would simply protect any living organ donor from losing or being able to obtain life or long-term care insurance, and would also protect them from discriminatory premium hikes on the sole basis of their having donated an organ. What I have found is that insurance companies have a wide range of policies, both written and unwritten, when it comes to this subject. And even those that do not discriminate now could do so in the future. Discrimination against living organ donors has, can, and could continue to occur without this law. The reality is that organ donors have to be in superior health in order to be a donor in the first place. They go through a very rigorous health screening before they are allowed to donate. Some insurance companies then punish them, calling their organ donation a medical condition. In practice, they should be giving organ donors discounts on their insurance, given that they have been proven to be in excellent health, and the fact that they have just saved another person's life, thus saving the company from paying out death insurance for that individual. This law is not asking for favorable or special treatment for living organ donors. It is just asking for equal treatment and protection against penalties. You can see that this bill has been co-sponsored by leadership in both the House and the Senate from both Republican and Democrat parties. I respectfully request an ought to pass as amended recommendation from this committee. John Hoffman, the Senior Director of State Policy and Advocacy for the National Kidney Fund, was not able to attend today, but I believe he has offered additional written testimony to this committee. He asked me to convey that if New Hampshire passes this law, it will be the 35th state to do so, with Mississippi and South Carolina being the most recent states to pass it. I would be happy to answer any questions you may have. Thank you, Mr. Chair and committee members.
Well, thank you for your testimony and for bringing the bill forward. Questions from the committee? Not all at once. All right. Thank you, Representative.
Thank you so
Appreciate
much.
it. Representative Tim?
Thank you, Mr. Chairman. Good to see you again. This is another bill that came out of Commerce unanimously and passed on consent on a voice vote. So I'm here today not only for Commerce, but as Chief Commercial Officer for a publicly traded organ transplant diagnostic company. And I have no conflict. We don't deal with living donors. We're primarily in lung transplant, and it's a very rare case where a living donor can donate one of the lower lobes of a lung. So it's a very rare case that there's a living lung donor. Our pipeline products actually might affect other organs. But we currently don't have any conflicts. But we do see the effects of the organ transplants. So this bill prevents disparate treatment of living donors in the underwriting process, as the representative said. So I would urge the committee to support this bill because we really need to encourage more folks to participate in this process. Representative Cambrels was one of the first representatives I met in an early social activity, and we discussed the national organ procurement process and how it's evolved over time and how it's changed and how New Hampshire specifically is affected as a small state, and how you almost have to move out of New Hampshire to be in a different area so you can more easily get an organ, because basically what has happened over time is the radius of allocation in metropolitan areas has expanded. So New Hampshire, for certain organs, is in the same area as Boston, New York, Washington, Philadelphia. Mm-hmm. So you compete for organs with the bigger cities. And that's actually changed over time. And each organ discipline crafts their own sort of guidelines. And that's changed for the better recently. But insurance companies, like Representative Campbell said, can potentially negatively impact living donors' decisions to get into that process, unless it's a relative or something. Anyhow, so it's the bipartisan support, broad support in the House, and passed on a voice vote, and it's a good thing for society in general. So please pass it.
Thank you
Thanks.
for your testimony. Questions from the committee? Seeing none. Well done. Representative Chris? I have a hard time reading. It's minus?
Munns.
Months.
It's all right. My handwriting is awful.
Yeah, so is my reading is off too, so. we'll work
Thank,
together.
thank you, Mr. Chairman and members of the committee. For the record, my name is Representative Chris Munns. I serve as one of the 4 representatives in Rockingham County District 29, representing the town of Hampton. I'm here today to speak in favor of HB 1155. I'm here to provide you with a personal story of why it's so important that we place no restrictions on anyone who wishes to be a living donor. My mother was always very active and energetic. Before emigrating to the United States, she represented the Netherlands in international competition. She was an avid bowler, and she enjoyed defeating my father in golf, something he very rarely acknowledged. Later in her life, she suffered complications from heart surgery that resulted in both of her kidneys failing. After spending months going to and spending hours connected to a dialysis machine, she decided that really was not for her, and she stopped going to those appointments. She passed away at the age of 79, shortly thereafter, and my sister, brother, and I were never more proud of her. Her experience dealing with kidney failure is also one of the reasons her oldest grandchild, my daughter, chose to go to work for the American Kidney Foundation, which, as you heard, has been leading the effort to pass bills like this around the country. My mother was not eligible for a kidney transplant, but had she been, I'm confident she would have embraced the opportunity to watch her grandchildren grow up and give her oldest son a hard time about his hair turning grayer and grayer every year. I do not want anyone else who might have that opportunity to be deprived of it, particularly if there is someone who's willing to donate an organ or part of one of them. If there is someone who wants to be a living donor and is willing to give someone else the gift of life, they should not be denied insurance coverage or have their coverage limited in any way simply because they have chosen to be a living donor. Ensuring that they will continue to be eligible to the same benefits they would have if they were not a living donor is the least that we can do for them. I hope you will join with me and my colleagues in the House who voted in favor of this bill and recommend it as ought to pass to your colleagues in the Senate. Thank you for your time, and I'm happy to answer any questions if you have any.
Thank you, Representative. Any questions from the committee? Seeing none.
Thank you.
Is there anyone here that wasn't given the opportunity to speak on House Bill 1155 but would like to be given the opportunity? With that, I will close the hearing on 1155. And we are done.
Are we dismissed?
Wait a little while and see if the others come back.
We can do that. You want to go into recess for till 11:30? I have a prime.
Which
We will be recessing until 11:30. And hopefully we will exec a few bills at 11:30.
I think the You need a motion to move into exec?
I need to bring us back into stuff. Hereby bringing Senate Health and Human Services back in. And do I hear a motion to go into exec?
So moved.
Second.
All right. Why don't we do 10, you got a list, right?
Yeah.
Okay. Yep, 1088, enabling schools to maintain a supply of epinephrine auto injectors.
Motion to ought to pass?
Madam Chair, I have in my notes that there's a housekeeping amendment.
And I've been told by the prime sponsor, she's talked to both, there were two organizations that wanted to make amendments. They're willing to wait because she's afraid that it may not pass if it goes back to the House. So she promised those two that next year she'll bring in a bill to kind of clarify.
So Pericles had approached me about this, so that covers
Yeah.
his housekeeping issue?
His housekeeping issue, and I think Beth Sargent had one too for the pharmaceuticals, but they said they would hold off.
Okay, perfect. So as long as, thank you, Chair Burzel. All right.
All right. So the motion is ought to pass on HB 1088. Any other discussion? Seeing none. All those in favor of 1088, say aye.
Aye.
Opposed?
Move consent?
Why don't we keep bills off consent just so we have a calendar that looks like a calendar next
Okay.
week?
I'll take this one out.
Anything for you.
And I think the next one definitely should not go on consent because people may want to talk. I would move ought to pass on House Bill 1296.
Second?
All right, we have an ought to pass on House Bill 11, wait, what?
1296.
Second.
Am I seconded or third?
Okay. Okay, who? Senator Bradley.
Yep. Senator Bradley moved ought to pass. Senator Avard seconded. House Bill 1296.
Thank you. All those in, any discussion?
I wanted the second, but that's fine, Cameron. I see you chose Kevin. That's fine.
First.
Tell you what, all those in favor of 1296, say aye.
Aye.
Opposed? Do you want to take it out?
Love to. Oh, that's very nice. So diplomatic. Oh, Madam Chair.
My wife was going to be
Is it?
disappointed.
Got a
that I
picture.
didn't-
You asked me to.
I'll get you one.
I wanted that one.
1171. Extending the commission to study environmentally triggered chronic illnesses. I'll move ought to pass.
I'll second.
Okay. Any discussion? All those in favor of ought to pass on 1171, say aye.
Aye.
Opposed? Would you like to take this one out?
Sure.
You're done. Okay. Last but not least, 1609. The Commission on the Primary Care Workforce and the State Office of Rural Health. I do see an amendment. You all have it? Okay. Does anyone want to speak to it?
A motion to ought to pass?
Oh, that's true. I'll second for discussion purposes. And I'll move Amendment 1416H.
Second.
Okay. Any discussion?
Just, yes, Senator Wurzel, just reflecting on the conversation with Representative Murphy. In doing this, it was pointed out that the committee felt that they needed to be more inclusive and have the direct primary care group called Direct Primary Care Frontier as part of, this commission. They felt that was an omission. They all agreed on it in committee, and Representative Murphy brought the amendment forward along with the bill.
Okay. All those in favor of Amendment 1416H, say aye.
Aye.
Aye. Opposed?
Move ought to pass as amended?
Second.
All those in favor of ought to pass as amended on 1609, say aye.
Aye.
Opposed? Senator Prentice, would you like to take this one up?
Yes.
Everybody gets one today. Anything else that you all want to discuss before we move out of exec? Okay,
Motion to move out of exec.
I'll second. All those in favor say aye.
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 Okay, we are out of exec. And I close the hearings on Health and Human Services.